The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. We are here for the next episode of TMD Demystified, and I am Tony Urbanic. Today's topic and title is the public and professional consensus regarding TMD, or if you will, want to call it TMD, TMJ. The public knows this problem as TMJ. Most dentists still call it TMJ. The physicians and the physician types, the physician establishment, calls the problem TMJ, but as you hopefully may know by now, temporomandibular joint disorder is the more appropriate name. I'm not trying to slice hairs here, just to make it clear that we're talking about the same problem. You can use TMJ, you can use TMD, you can use TMD/TMJ. All of it's okay with me. I hope you know what we're talking about. We're talking about this rather huge problem. The volume of people with this problem, primarily females, is I've calculated it's 45% of the female population has TMD symptoms. And by the way, while it's on my mind, I call it TMD disorder because it is one disorder. It is not disorders, and we're gonna talk about that, if you will. That word will unpack it a little bit more as to why it's a disorder, not a plural disorders, because it all boils down to one constant, simple cause. So if it is one cause, it is a disorder. It's not a multiple disorders. It has multiple symptoms for sure, but it is one disorder. And that is what this is all about. This is what TMD Demystified is all about, educating and enlightening both the professions and the public in the process of what TMD disorder is all about. So today we're going to talk about the public and professional consensus regarding TMD. What is the consensus in the public and the professions regarding TMD? I can sum it up in two words: nothing works. And that is a simple consensus, but if you ask the average dentist, if you ask the average physician who knows or has experience with any patients with this problem, they will be the first to tell you nothing works. That is the consensus out there. Now, there are exceptions to every rule, and there are exceptions to this consensus. By definition, is a consensus, an agreement of the majority. And it's not just a majority, 50% or 60% versus 40%. It's the vast majority, 95% or higher, probably much higher, probably 97%, maybe 98% versus 2% of professionals and patients know nothing works. Although we have figured out what does work, and I won't promote that till the end. We'll say it again, but the issue is the consensus, which is really sad, and that's been the consensus for my entire career, almost 50 years now, of treating this problem first surgically, and it is in prior episodes why I quit treating TMD surgically quite some time ago, and why I did the research and figured out what the common denominator of this problem is and how to solve that common denominator, making the symptoms diminish and go away. But I wanted to really focus on this issue of what's the consensus and why it's the consensus and why the consensus is nothing works. And there's multiple parts to this. And, you can't really understand a problem unless you understand all the parts of the problem and a little bit about the history of the problem. And hopefully, each one of these episodes on TMD Demystified will get you a little closer to a full understanding of what I know about this problem and what we apply to make those symptoms go away. But the consensus is nothing works, and each of the participants, which are generally physicians, dentists, and of course patients, have a little different point of view on it. And that's what I wanted to talk about. And then looking at their point of view, why they consider then nothing works. Being both a dentist and a physician, it gives me the opportunity to run both rails. I'm also trained as an academician and as a researcher with skills well honed, used along those lines. So I really can't be misled by any one profession. I have great affiliation and great admiration for all of my areas of work in dentistry, in medicine, and in academics. But I can tell you that each of those areas of the sciences operate quite differently. They are not the same. They don't operate the same. Physicians don't think like dentists. Dentists don't think like physicians, and the academicians don't think like either one. And so operating in all three fields successfully and significantly my entire career leads me into a very unique position to make comments. I don't claim to know everything, and a lot of what I can say is my opinion, of course, but most of what I have to teach are facts. And when I come up with an opinion, I will be very careful to say, now the next thing I say is going to be an opinion, not a fact. So let's start out with the dentist. They are the most obvious because really, unfortunately, the treatment, the investigation, and then the treatment for TMD has been left up to the dentist. And I say, unfortunately, because the dentist and the dental profession was not up to the challenge. It really wasn't a big challenge, as far as I'm concerned. When I look back at my experience, starting as a surgical provider, doing oral and maxillofacial surgery, starting in depending on how you view it, 1981 is when I started my private practice. 1978 is when I finished all my training, which included dental degree, medical degree, master's in science and cell biology, all the work on a PhD, except I did not publish my thesis. So I don't claim the PhD in cell biology and anatomy, but I did all the work except publishing the thesis. And that's another story why I didn't. There's a very good reason why the thesis was not published. Although it was validated, it was very valid, but getting off point. The perception by the dentist is nothing works because they're faced with an increasing number of mostly women who come to their office with these odds disparate symptoms. The understanding of this problem has not been done, starting with the dental schools, which teach everyone. Every dental student is taught this joint called the temporomandibular joint is very unique, very different. It's not like any other joint in the body. It's definitely different. It's definitely complicated, and we haven't figured it out. And that is what they are taught in dental school. So anyone who has any maybe kind of interest in pursuing treatment of or even understanding of this joint is suppressed right away by being told it's unique, it's different, it's complicated, and we haven't figured it out. And young doctor, you're certainly never going to figure it out, which is actually invalid and not the truth. Other aspects of why it actually is very simple are covered on many of these other episodes, but that is where it all started. It started from the fact that dental students are taught that it's complicated. And the dental profession was given and left to treat this temporomandibular joint when they were not prepared in any way, shape, or form to treat a joint. But this joint, temporomandibular joint, works like every other joint in the body, and that is a fact. That is a fact, and that is where it went off the rails, because they were looking for unique and different kinds of operations coming from this temporomandibular joint. But when you look at it from the viewpoint that it operates like any other joint in the body, the solution comes into view very quickly. If the orthopedic surgeons had been left to treat and understand this joint, including all the other joints in the body, this joint would have been solved long, long time ago. Unfortunately, the orthopedic surgeons were totally scared away by the fact that this joint is connected to the jaws, which is connected to the teeth, so it must be dental. That is how it happened many, many years ago, basically a century ago or more. Orthopedic surgeons, doctors who treated bones and joints, no, this is connected to the teeth. This is out of my wheelhouse. It must be left to the dentist. And that was a mistake. Truly, it was a mistake. But here's where we are right now. There is a move afoot, I'll just say as a sidebar, there is a major move afoot to coordinate the actions between physicians and dentists. And I think it's going to improve things significantly, but as I'm looking at it, physicians are never going to take control of treating this temporomandibular joint. It will always be left to the dentist or dental types, doctors with dental information, trained in dentistry, that are going to be left with treating this joint. So you must have a dental degree and some kind of dental training. Again, basically because it is connected to the teeth, and the way the bite functions with the jaw and the jaw functions with the joint has everything to do with what's going on in this joint itself. So the dentists are faced daily with primarily females entering their practice or in their practice complaining of headaches, earaches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, vertigo and dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking, and of course, lots of different kinds of joint noises. Those are the majorly accepted major symptoms of TMD. There are other significant symptoms. To name one right off the bat is a lot of patients feel that the pain is coming from a tooth, and they go to a dentist because it must be a tooth, so you must go to a dentist. And the doctor does his due diligence, takes the x-rays, examines the tooth. We know how to, it's very easy to determine whether the tooth itself and the nerve inside the tooth is damaged. We do our different, very simple study. Is that nerve healthy, or is that nerve inside the tooth not healthy? Is there decay? Is there not decay? Is there a fracture of the tooth? Is there not? You go through that and looking at an x-ray or two, and you can tell right away whether that tooth is causing pain. And a lot of patients will complain the teeth are causing the pain when actually it's the jaw joint that is actually creating the symptoms. And then they talk a dentist into taking out a tooth or two, the pain continues, and now they have a couple missing teeth that didn't need to be removed. This is not unusual. This is actually one of the commonplace occurrences in a dental practice. The younger dentists have no basic training on temporomandibular joint disease coming out of dental school. They're lucky to get basic training on extractions and dental implants. And I mean very, very basic. They come out of school with minimal training in those areas. And certainly no training in temporomandibular joint problems. If a dentist is going to get any kind of training, he's going to have to do it after he leaves dental school when it comes to treatment of the temporomandibular joint, which is the major reason why dentists have no knowledge of it and don't want anything to do with it because they know nothing about it. And their experience is that no matter what you do for a patient with temporomandibular joint symptoms, the symptoms continue to recur periodically and get worse over time. And they believe that the TMD patient is nothing more than a drag on their practice, and they do everything they can to avoid the TMD patient, except for a few. I call them unceremoniously the TMD gurus who just throw things at the wall to see whether they will stick or not without understanding the basic sciences of what actually this disease is all about. I mean, you can, as you might imagine, whether you be professional or public, take any kind of modality as far as a treatment and apply it to see whether it works or not, without understanding what the actual cause is. And this doesn't fly very well in the profession of medicine. And increasingly so, this kinds of action does not fly very well in the profession of dentistry. But generally speaking, the dentists are well familiar with the problem. Most of the dentists, or at least 50% of the dentists, will make a night guard, which is a plastic covering of the teeth themselves, either upper or lower, hard or soft, which protects the surfaces of the teeth for the patients who clench or grind. And it does protect the teeth, does a great job of protecting the teeth, but has no effect on the temporomandibular joint symptoms themselves. And I'll explain again in a minute why that might be the case, why that is the case, factual case. So 50% of the dentists don't want anything to do with treating a TMJ patient because it's a drag on their practice, and they hope the patient doesn't show up, or if they show up, hopes they go away. And 50% of the doctors make a night guard, give it to the patient, and tell them this is their TMD treatment and hope they don't come back. Those are facts, and I've taken that up with hundreds and hundreds of doctors, dentists, personally, and I have never had a dentist disagree with that statement. 50% make a night guard, 50% don't want anything to do. And then there is that 1/10 of 1%, the TMD gurus who throw things at the wall to see whether they stick or not without understanding the pathophysiology, big fancy word for what's the causation, how does it work within the body mechanisms. And that's what I discovered, that's what I found out, that's what I teach about, and that's what we talk about on TMD Demystified. And then there are the physicians themselves who are faced with these patients with these very disparate symptoms constantly. Now, when I say physicians, that could be any number of physician medical profession types, starting with the PCPs, ENTs, neurologists, the physician's assistants and nurse practitioners who man the convenient care clinics, which are literally on every corner now and in a lot of grocery stores. Mostly the walk-in clinics or convenient care clinics are manned by physicians' assistants, nurse practitioners occasionally. Nurse practitioners are more likely to be the assistants in ENT practices, large ENT practices, large PCP practices, and they will have little to no knowledge unless they're taught specifically about the symptoms and the treatment of TMD, but they see the patients with these very disparate symptoms. Again, to repeat, disparate meaning disjointed and way out of bounds without connection: headache, earache, jaw pain, neck pain, ringing in the ears, fullness in the ears, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And for a physician which has no training in the dental sciences, these symptoms are so disparate they don't make sense. If you have a patient who comes in with chronic pain of the upper head and the opposite side shoulder pain, the physician or physician assistant, nurse practitioner is going to say, that makes no sense at all. That makes no sense to me. And the physicians themselves at least as I practiced in that arena, I was constantly told, I just tell the patient they're crazy. It makes no sense. And they would add, why do you want to treat these TMJ patients, Tony? I mean, you know, they're crazy, which is totally not true. It is not true. I've certainly learned that by experience. If anything, these patients are crazy with pain. They're crazy with frustration. They're crazy with having daily symptoms that are increasing over intensity, that ruin their life, that no one has an answer for. A lot of people don't even, a lot of professionals don't even want to hear about it, but they know they are suffering tremendously. You can imagine this can make a patient look and sound very crazy. And no doubt, I have dealt with many patients who come in emotionally charged one way or another, very emotionally charged, but that does not make them crazy. That makes them very, very frustrated. And that is a fact. So I want to emphasize the need for empathy for these patients. I want you to really get that. And with great experience, I mean, I'm not bragging when I've said I've done well, excluding any surgical consultations I've ever done in my career, which I did in the first 36 years. 14 years ago, roughly, I quit doing TMJ surgery and went on the research looking for the solution. But for the first 36 years, we won't even count the innumerable consultations and surgical procedures that I performed, which were roughly 2,000 TMJ surgical procedures, until I went the non-surgical route. And since then, I must have easily done 8 to 10,000 consultations. I know that I've treated non-surgically, now approaching 5,000, personally 5,000 TMD patients non-surgically. So all I'm saying is I have a lot of experience with these patients, and I have a lot of empathy for these patients. So the physicians call the patients crazy. The physicians don't know what to do, or physicians type. The nurse practitioners and physicians' assistants, as it turns out, they know they don't know. So they are like sponges when you try to teach them about TMD, because I have lectured to large physician assistant nurse practitioner groups, and the topic and the subject was really brought to mind in them, and then they thanked me for bringing all this information to them because they know they don't know. MDs are a little different. It's pretty hard to educate an educated MD, but with a little time and a little experience, I have made great breakthroughs here in Middle Tennessee, where this all started, with the MDs, nurse practitioners, ENTs, neurologists, who, as a group, including the dentist, like refer us. We have 900 referral sources through the professions: dental profession, medical professions, walk-in clinics, chiropractors, physical therapists. So the physicians know that nothing works because, first of all, it makes no sense. And if they even suspect it may be having something to do with the joint because the joint makes noise, or the patient points to the joint, or the patient says, I think I might have TMD, doctor, what do you think? His only solution is go see your dentist. They have no solution. There are exceptions to that. The ENT doctors or PCPs who misdiagnose this problem as Meniere's disease, which is 3 symptoms put together called Meniere's disease: ringing in the ears, fullness in the ears, which is subjective hearing loss, and dizziness, vertigo. By definition, that is what is called Meniere's disease. The ENT doctors do a $2,000 or $3,000 workup, probably include an MRI, and say to the patient, you have Meniere's disease, but we don't have any solution for Meniere's disease. But we know those 3 symptoms play a large part in temporomandibular joint disease. So here in Middle Tennessee, we have an increasing number of ENT doctors who are now aware of our work here in this particular practice, in our practice, and send us large numbers of patients with ringing in the ears, fullness in the ears, subjective hearing loss, and vertigo, knowing that we have a solution for those symptoms. We just don't call it Meniere's disease, because Meniere's disease is a disease that is treated by the ENTs that they have no solution for, if you get the gist. But that is another reason that the ENTs, that there's no solution for TMD except the educated ones in this particular vicinity and the other doctors who join our network of doctors using our device and protocol. So it's a very expansive thing. The walk-in clinic ladies and nurses, practitioners, they know they don't know, and they're willing to learn. The physicians are a little harder to convince that there is something that works. And then, of course, the patients themselves. Now, that's where the heartbreak is, because the patients know there's nothing works because a large majority, and I do majority, that means over 50%. I've not done a study on how much over 50%. That would take a scientific, academic, statistical study. But a large portion of the patients we see here, over 50% of them have been seen by multiple practitioners in multiple different professions, looking for solutions to their symptoms that can go on for 10 years, 20 years, 30 years, or longer. And so after a decade, or even after 5 years of increasing symptoms, increasing in intensity, and cycling frequently, they know that nothing works because they already tried home remedies. They've done things that have been recommended by other dentists and physicians who misdiagnose the problem as Meniere's disease or migraine headaches, which is extremely common, or if there's anything having to do with ear pain or pain in and around the ear, commonly misdiagnosed as ear infections. Those are the 3 big misdiagnoses that occurs. And so patients who go through this process for a few years to a few decades, they are convinced that nothing works. And that is the reason they come in quite frustrated and quite emotionally distraught, but they're not crazy. So you can see why the public and professional consensus regarding TMD is nothing works. The things that they throw at the wall are symptomatic relief at best. Let's take the most common one. Everyone has jumped on the Botox wagon here recently, within the past 5 years. Big time. Botox is the answer. Promoted, advertised highly as a solution for TMD, although it is not FDA approved for the treatment of TMD symptoms. It has to be used off-label, as it's called. But if you have a muscle that's tight, and we can explain here in a minute how the common denominator creates tight muscles, but the point is, if a muscle gets tight and the patient complains, it hurts here, right there, not knowing it's called the masseter insertion of the masseter muscle, right there, right across there, but it hurts right there. Any doctor, nurse practitioner, walk-in clinic, dentist can inject Botox or botulinum toxin A, which is the generic version of Botox, into the muscle. The muscle will be paralyzed. It won't pull on the bone. It won't hurt. If a paralyzed muscle can't pull on the bone, then it will not create pain, and that pain will go away. But when that pain is also associated with ringing in the ears and shoulder pain, and something maybe feels like my tooth hurts, that particular symptomatic relief doesn't affect any of those other symptoms. And most of these patients have multiple symptoms. It is very rare, very rare, that we find, after doing consultations on approaching 8,000 temporomandibular joint patients, that they don't have at least 5 or more of those 10 symptoms. Most of them have more than 5. A great number of them have all 10. When you ask them, do you have this symptom? Is that a symptom? Is this? Yeah. How did you know? How did you know is what frequently we hear, how did you know I had that? It's because the common denominator of temporomandibular joint problems creates each and every one of those symptoms. If you make the common denominator go away, the symptoms will go away. So the patients are well versed on knowing that nothing works, and they are well versed on doctors throwing things at the wall, throwing things at the symptoms themselves, which will give at best temporary symptom relief, dry needling, as I talked about, Botox, chiropractic treatment, relaxing muscles, by various means. Chiropractors are excellent at relieving muscle pain, but it does not address any of the other pains, especially when they're different parts of the body. So what is the common denominator? The common denominator that creates all of those symptoms that I've now listed twice is inflammation within the temporomandibular joint. It's just inflammation. When you know about inflammation, when you know the science behind, and you know the cell biology of inflammation, of which we don't know all of the cell biology. There's a lot about inflammation we do not know, but we know that inflammation stimulates the autonomic nervous system to cause muscles to get tight so the joint does not work. This same phenomenon is well known with the orthopedic surgeons as it applies to any joint in the body, but the one that is most vocalized is tennis elbow. Too much of rotation or movement of the elbow, tennis elbow, can create inflammation of the lateral epicondyle, which creates muscles to get tight, which moves the joint. That joint sends a signal to the central nervous system at the brainstem, says, I'm inflamed. The brainstem says, I'm going to help you out. Tighten up the muscles. Don't move the joint. Tighten up. Don't move the joint. And that causes forearm pain, not elbow pain, forearm pain. When this joint becomes inflamed, chronic inflammation, which does not go away by too much damage or use, because there are only three causes of damage to the joint itself creating chronic inflammation. Only one of them is bruxism, clenching and grinding. The other two are acute trauma, trauma to the jaws themselves. And the third is functional malocclusion, which is jaw dysfunction and or bite dysfunction, which overloads the joint, creating chronic inflammation. But the common denominator is chronic inflammation in the joint, which creates the signal to tighten up first the muscles of the jaw, muscles of mastication, which can some days be up here, and because these muscles are all over the side of the face. You got the temporalis, the masseter, the mylohyoid, internal, external pterygoids. Those muscles get signals to get tight. They pull on the bone. Where they attach to the bone is where it hurts. And then it spills into the neck because if the chronic inflammation continues, the signal gets stronger and broader. So it goes, we said tighten up the jaw, now tighten up the whole head, and then tighten up the whole shoulder girdle. And patients will actually complain when that happens of shoulder pain, chest pain, and arm, hand, finger tingling and numbness because it squeezes the brachial plexus, muscle squeeze the brachial plexus. All anatomically explained, all explained by a little bit of knowledge on cell biology and the nervous system and the autonomic nervous system, sympathetic portion of how that works. For every joint in the body, they all work the same way. There is no difference. They all work the same way. So what you, the doctor, was taught in dental school was not correct. This is the big lie, which really developed into the issue of the public and professional consensus regarding TMD. Nothing works. Enough said. Probably a little bit too much, maybe. If you would like to learn more about how to use a very simple device that unloads the temporomandibular joint, just like a set of crutches unloads a bad knee, because the best way to make the inflammation go away is not Botox, because you can't inject into this joint. Certainly want to inject Botox unless you want to make the whole face numb. because you're going to miss the point and you're going to get it into the structures of the facial nerve. That would not be good. But if you want to learn how to use it by unloading the joint using a very simple device, you can learn more about it by going to our website, www.urbanictmj.com. You can contact me personally at tony@tmjservices.net if you would like to criticize or ask questions, or if you want to compliment, that'd be great. I can be reached. I'd be happy to respond to any questions that you might have about this problem. I'm not going to be able to treat all these people by us, a few of us in Middle Tennessee, and we now have an expanding network of doctors who are licensed to use this particular device and protocol, because it has to have a protocol. It's not a widget. You have to know how to use it. You have to be licensed. You have to take a brief but very meaty course on the nuances of using the device and protocol. The success rate is extremely high based on the science that has been done and an independent study done, which proves our claims that you get 90-95% success rate. And the ones that we don't have success rate are pretty much patients who will not follow the protocol. Enough for today. I have plans for future episodes. I always look ahead a month or two. I have, I think, some very interesting comments to speak and topics to talk about to bring home the issue of TMD Demystified. I'm Tony Urbanic, and I look forward to the next time that you'll visit.